in this case.
Good afternoon.
Please, thank you.
Chairman Hill, Chairman SALAS, members of the Joint Committee. I'm the president of the State Board of Pharmacy, and I represent the 11 other professional and public members that make up the focus team that develop the strategic direction for pharmacy practice in our state and provide our executive officer and staff with oversight. The Board of Pharmacy is an active consumer protection agency that regulates the pharmacy profession. We regulate all who dispense, transport, and distribute compound sterile products within a pharmacy. We regulate and promote the evolving practice of pharmacy, including those recently enhanced by Senate Bill 493. The board composition is 13 members, 7 pharmacists, and 6 public members. The Senate Rules and Committee and the Speaker of the Assembly each appoint 1 public member. The other 11 members, 4 public and 7 professional, are appointed by the governor. Currently, the board has 12 appointed members, with 1 public member vacancy awaiting an appointment from the Speaker of the Assembly. Pharmacists practice in a wide variety of practice settings. Retail pharmacies, I'm sure we're all aware, and we see pharmacists when we go pick up medications and prescriptions. Pharmacists administer vaccines, and they're a very vital health point of contact. There's hospital pharmacists that provide 24/7 pharmaceutical care for urgent hospitalized patients and emergency room patients. There's nuclear medicine pharmacies that prepare radioactive isotopes. There's sterile compounding pharmacies that prepare critical meds that are injected into the vein, the central nervous system, and also instilled into the eye. Some of these products are produced from products that are not sterile. They have to be sterilized as part of the process, and they have to be done in a manner that's not going to cause an infection to the patient as a result of medication administration. Also, pharmacists manage medication therapy in hospitals and institutional settings through collaborative practice agreements. So they adjust doses of therapy and maintain medications for patients. Pharmaceutical care is critical to the health and safety of all Californians, as medication is usually the most effective and efficient way to treat and cure disease. From vaccines, antibiotics, hypertension therapy, and cancer therapies, safe medication therapy plays a pivotal role in curing disease. The pharmacist is the professional that manages this critical therapy and ensures that the patient receives the right drug, the right dose with the right instructions, along with the person-to-person counseling that is very important to keep our patients engaged as partners in their therapy. We understand that the right drug, right dose, and right instructions mean little if the consumer that's receiving that prescription drug does not understand how to take the medication appropriately to achieve the best outcome. The statutory mandate about the board is consumer protection and ensuring that each one of us as consumers receives appropriate care. As outlined in the Sunset Report, the board has just over 100 employees with an annual budget of over $20 million, 23 licensing programs. We license 140,000 licensees, which includes over 47,000 pharmacists, 7,100 pharmacies, 1,000 sterile compounding permits, and 74,000 pharmacy technicians. Other license types include drug wholesalers, which ship drugs into the state as well as within the state, and also clinic permits. We receive approximately 20,000 applications a year and regulate both in-state and non-resident businesses that provide and ship medications into California. Over the last years, the board has developed and implemented a number of policies and regulations that are focused on ensuring optimal medication quality and safety to the patients of California. And there are ongoing processes for monitoring the pharmaceutical services that are provided by professionals licensed by the board. I'm just going to highlight some of the examples and the board's impact on the lives of Californians since the last Sunset Review. Sterile compounding. You may recall what happened nationally as a public health emergency in 2012, which was announced by the CDC as a result of their investigation of a multi-state outbreak of fungal infections, which were found to have originated from a sterile compounding pharmacy in Massachusetts. That pharmacy had sold the tainted steroid compound to a variety of states. To date, there have been 64 deaths and hundreds of individuals that have been infected with meningitis, spinal and joint infections, and those that still live continuing to receive treatment for these infections. And now it's 3 years ago, and they're still receiving these therapies. The states worst hit in the U.S. were Michigan, Tennessee, and Indiana. While there were no deaths or infections reported in California, we were fortunate. The State Board of Pharmacy took immediate action, and we increased inspections of pharmacies through the state and that prepared sterile compounded drug. As a result of Senate Bill 294, Emerson, annual sterile compounding inspections of all pharmacies are taking place, including inspections of out-of-state pharmacies that ship sterile compounds into California. So we actually do have inspectors traveling there and inspecting these locations. Another example, prescription labels. In an effort to increase patient engagement and care and improve the ability of customers with limited English proficiency to read and understand their prescription labels, the board worked with Assemblymember Tang with AB 1073 in 2015, which supported translated directions for use in 5 languages for standardized directions for all licensed pharmacies. This supplements the availability of the oral translation for consumers that was developed as part of the initial rulemaking for patient-centered labels in 2010. The board standards for patient-centered labels have been recognized by 3 national organizations as standards throughout the United States for prescription label design. We're in the midst of an opioid epidemic. The White House Summit on Opioid Epidemic, prescription drugs are involved in half of all poisoning deaths, and drug poisoning deaths have now surpassed national deaths on gunshot wounds or motor vehicle crashes. So more people are dying from drug poisoning than motor vehicle accidents. The board has developed a multi-pronged approach to combat the prescription drug abuse epidemic, which includes consumer and licensee education, aggressive enforcement of the board's licensees that elect to divert drugs or dispense controlled drugs for profit. In 2013, the board designated a precedential decision in a case involving a pharmacist who did not exercise appropriate corresponding responsibility. That's posted on the board's website. Acknowledging that there's a readily available antidote for opioid overdose, the board in 2015 also created a state protocol pursuant to Assembly Bill 1535, Bloom 2014, for pharmacists to dispense an antidote for opioid overdose naloxone without a prescription. And this can be dispensed or furnished to a patient or a family member who elects to have naloxone without a prescription. Adopted first as an emergency regulation in April 2015, the final permanent version is now in use throughout the state, and there are pharmacies that are dispensing it now. In 2012, the state medical and pharmacy boards, along with the DEA, held a 2-day summit on appropriate prescribing and dispensing to educate providers and pharmacists about the growing opioid epidemic. The board has been instrumental in educating and promoting the use of the state's prescription drug monitoring program, CURES, to all licensees. Currently, over 50% of the board's licensed pharmacists are enrolled in CURES, with our goal to have that number at 100% by July 2016, so that pharmacists can actually assess prescription history and look for patients that are drug shopping or physician shopping before the medication is dispensed. Senate Bill 493 was signed by the governor. Pharmacists were provided the ability to extend patient care options in California. Implementation of SB 493 allows pharmacists through statewide protocols to provide smoking cessation agents, vaccinations, self-administered hormonal contraception, and medications for those that travel outside of the United States. Additionally, the board has developed the framework to license the nation's first advanced practice pharmacist, which is focused on increasing access to medication management services to consumers across the state. California is a pioneer in this field, and we are setting the stage for expanding these services to other pharmacists in other states that are looking at what we're doing and planning to follow. In 2015, September 2015, you may recall that the governor announced a state of emergency due to wildfires And the board developed emergent consumer-focused actions to promote access to those that were taking critical medications but didn't have access to their prescription or to their medication vial. We had an emergency meeting, and within 2 days, we had issued emergency regulations and promulgated them and sent them out to all pharmacies, letting them know that these patients had access to medication, even though they didn't have the prescription with them if they were involved in the wildfire. The Board of Pharmacy strongly believes in the role of the pharmacist in patient consultation. Ensuring that each consumer clearly understands the directions for use is pivotal to improving our health care. You can give someone the right medication, but if they don't take it right, it's not going to impact their health. We want them to understand. So starting in 2007, the board collaborated with 3 county district attorneys' offices in pursuing pharmacy counseling violations. And these county district attorneys' offices have collected fines from 3 of the chain drugstores for violations of California's unfair business practices statute for failing to provide patients with consultation when required by state law. The board is nationally recognized as a leader. The board's executive officer has testified before Congress regarding price gouging of hospital pharmaceutical sales by secondary wholesalers. She's also represented California at a 2015 CDC International Conference on Emerging Infectious Diseases and presented on medication contamination and counterfeiting. She was elected to serve on a Pew Charitable Trust Blue Ribbon Committee to develop best practices for sterile compounding pharmacies and outsourcing facilities, and this recognized California's national leadership and prominence in this area. She's presented at 3 FDA 50-state meetings on sterile compounding and regulation of drug wholesalers and third-party logistic providers, communicating our state's proactive actions towards consumer protection in all these arenas. We've been asked to develop guidance on the end-of-life options now that the governor has signed this bill into law, and we're actively working with the medical board and with the department on identifying options and guidance for pharmacists so that this can actually be rolled out throughout the state. We're also in the process of promulgating regulations on pharmaceutical take-back, so those have actually now out for public comment, and we have meetings in April that will be public hearings to hear feedback on the draft regulations that have actually been already released. I'm proud of being a pharmacist within our great state and truly believe that the pharmacist's role is pivotal to attaining good health outcomes. In my 32 years of pharmacy practice, I can't recall a more exciting time for our profession, as the ability to provide direct health impact to consumers has never been greater. I'm also proud of leading a state board that is focused not only on public protection, but also on the promotion of health outcome through the active development of policy, education, and regulations for the public we serve. There have been several questions that have been asked by in response to our sunset review today, and I will we'll go over some of those, and I've got Ginny Harold, who is our executive officer, and Ann Sodergren, here as well from the board to help with these responses. So the first one is regarding what improvements still need to be made. We need to secure enactment of some of the multiple regulations that are at varying stages of completion. We acknowledge that. One of the things that I'm relatively new to the board, I've been here for a couple of years, but I didn't realize before taking on this role how long it takes to get regulations through, all the multiple steps that are involved, and something new to me as a pharmacist. We need to secure a fee to increase current level of operations, and I think that's in the sunset report as well. Address issues involving the licensing of automated dispensing cabinets and machines to provide medication. We are to require a patient to have to go back to a pharmacy to continually pick up medications. We need to increase access options. We have a pilot ongoing in San Diego for a medication dispensing device that will release patient prescriptions that are already filled and complete to patients, so it will give them other options as well. But we need to look at ways of licensing these machines so that the board staff and the board is aware of where they're located. We want to improve communication with board licensees on changes in law, the responsibilities of a pharmacist in charge, and evolving board policies. 2 tactics that we're undertaking is performing more routine, unannounced inspections more frequently rather than the inspections being for cause. We also are going to be looking at supervising inspectors, contacting licensees to obtain feedback regarding routine inspections so that the board actually gets responses back and gets input from the licensees on how we're doing. Ginny's going to cover the fund condition.
Okay. Well, I've been asked to explain a little bit about, is the board appropriately directing staff resources to meet its mandates and its needs? Well, the answer to that is that enforcement is at the very core of what we do, and that's where we spend the bulk of our money. Right now, we're spending 57% of our budget overall on enforcement-related expenses, which includes, out of a $20 million budget, $3 million for prosecutions at the AG's office. Keep in mind that pharmacies, unlike a medical practitioner that sees one patient at a time, pharmacies have the ability to affect large groups of people at the same time through what they do. The staffing of the board also reflects our focus on enforcement, where we have 62% of our staff doing enforcement duties, 24% doing licensing, and the remaining 14% doing admin-related things. Is the board's program going beyond what fees can cover? Regrettably, yes. Our fees are no longer commensurate to keep us in a solvent position, and that if we continue at our current rates of expenditure, by July 2018, without a fee increase, we will have a problem. Our fund condition at the end of this year was 5 months at the end of, last year was 5 months at the end of June. This year, we're looking at 3 months at, and then another year from now, we're sitting around 1%, and then after that, we go deficit. So we have a little time, but we desperately need a fee increase, and that is part of another proposal. Did the board properly evaluate licensing fees for new categories like sterile compounding facilities located in other states that provide drug products to us? The board at the time the bill was going through took a conservative approach, and we used it based on what we were currently using to inspect then what were the sterile compounding provisions that we'd had in place since 2003 when we had a sterile compounding problem in California. But it was not enough, and we're finding that the inspectors are spending more time in facilities, particularly in large facilities out of state, which generate a lot of the medication that's being shipped in. What efforts is the board taking beyond a fee increase to mandate a healthy fund condition? Well, we have limited options in this area because we already make use of various forms of technology to do what we do. We have 20 systems that we've developed over the years to track various things so that we can be on top of things. We don't have a lot of staff for all of our applications and all of our licensees, so we try to manage that way. And then finally, we also are making better use of telephone and webinars to deal with our statewide staff. We have 46 inspectors and their supervisors who work from home offices that are scattered throughout the state. It's efficient in that we don't have them reporting to an office every day and then traveling out into the field. It's inefficient when you try to get them all together. So we are doing more use of just simple things like telephones and webinars. We have a weekly supervising inspector meeting now that we have 8 supervising inspectors to make sure that they're working collectively together and with the managers, and that we can bring in what the board has told us during board meetings or through telephone calls or sitting in sunset review committees about what you need to do in order to direct staff better. So those are some of the efficiencies we've done. So, and that's really what I have right now.
So with respect to licensing backlogs, the board does not believe that it does have a licensing backlog currently, but regrettably we did in 2014 and through 2015. The board's current processing time for all of our high volume licensing categories is at or below 31 days from the receipt of the application to the initial review. Further, the board's current processing time for deficient items is running about 35 days or less, again, depending on the licensing category. The board believes that we do now have acceptable processing times, and we will continue to focus our efforts there and work to maintain and or further reduce them. The board recognizes that its important role in allowing both individuals and businesses to enter the marketplace, and a delay on our part has a negative impact both on those individuals as well as the public. The board's expectation is to process applications within 30 days of receipt, and we will continue to focus there. We are also trying some different models in terms of how we are going to further improve our services to our applicants. Because of surges in workloads that occur because of like large corporate chain buyouts and things like that, previously, historically, that has become the focus and staff are redirected to assist there. We are trying a new strategy and dedicating resource to focus specifically in response to those corporate buyouts, as well as also working with applicants that submit deficient applications. Sometimes the applications have a tendency to languish, so the person is focusing there doing outreach to the applicants to see what we can do to help facilitate getting the application deficiencies remedied and so that a license can be issued. The board has also initiated a modest campaign, educational campaign, to assist our applicants in understanding what the requirements are and the application process. Currently, our staff focus in 3 primary areas with respect to our licensing functions: processing applications, processing deficiencies, and responding to status inquiries. If we take care of the education up front, we're going to reduce the number of deficient applications that come in. That means that the staff that are currently focusing on the deficient items are going to be able to really focus on just processing the applications at the front end and getting people licensed more quickly. One specific question that was asked was whether or not the board has directed too many resources to enforcement. And as Ms. Harold indicated, enforcement is our core. Enforcement staffing is dependent on enforcement cases managed by the board. Thus, the staff related to enforcement functions is really commensurate with the need. By law, the board issues licenses to a site and not a corporation, and so one of the other areas that we are focusing on is the board has the ability to use a headquarter system for large chain stores, and with that headquarter system, it facilitates more easily the renewals and the application process for those individuals because that information is centrally stored in our system. We are coming up with a master file that will be used on a smaller basis for those people that do not have as many businesses, 75 or more, that can use this master file so they can again centrally store the common ownership things, and that should also remove some impediments to becoming licensed more quickly.
Okay, back to me. Question?
No?
Okay.
Well, I have a couple, but I'll wait till you.
All right, thank you. I've been asked to address enforcement prioritization, and one of them is, are the board's inspectors becoming too overzealous? In the last couple of years, we've added a number of new inspectors. That's where one of the areas where we've had the most growth. For example, in July 2014, we added 10 new inspectors to the board's contingent of inspectors at that point. These are pharmacists, again, that work from home offices. So the concern is that these people work in the field, and there are investigators that when they walk into a pharmacy, they need to have a particular demeanor and not throw open the door and say, the Board of Pharmacy's here. It's really important that they don't disrupt the operations, that the pharmacy can continue to operate, and that they can take care of their inspection or their investigation in a manner that does not disrupt. And so one of the things we constantly work with our staff is to make sure that they have the appropriate demeanor when they go into pharmacies. It's just too potentially a loaded situation for them. Sometimes we have complaints, although we have amazingly few, given that we have 46 field staff that are out constantly doing inspections. We get perhaps 1 or 2 at the most complaints a year. The complaints are handled by going directly to either me, because more likely I'm going to get the call, than the supervising inspector, who the pharmacy may not know who the supervisor is, in which case the supervising inspector handles it. We address it with the pharmacy, we address it with the inspector, and we make a regular note on it, much like you would any employee you need to coach and change their behavior. We then move on. But one of the things, as Dr. Gutierrez indicated, that we are going to start to do, and we've already got the survey document developed, is our supervising inspectors will now do post-inspection surveys of the people we license as a proactive measure to find out what's working, what's not working, and how we can improve from the pharmacy's perspective. So that'll be conducted by a supervising inspector. The information will be culled and put in an unnamed format so that we don't have individuals highlighted, but so that we can show what has in fact been said and build it into our model as a way of providing better service to the public and to our licensees. We're also requiring our supervising inspectors to do something that they do while they're training inspectors and maybe at the time of an performance evaluation, but not routinely. We're going to require them quarterly to go out with each one of their inspectors on an inspection and observe what's going on just to see what they're doing, see if they need additional training, see if there's some additional hints or something else that the inspectors need to be more proficient and more appropriate in the event that that is a problem. We do not think that that's a problem, by the way, in the field. And the final thing, as I mentioned, that any complaint that does come in ends up with me at one point so that I am aware of what's going on. We also get compliments about our inspectors. I don't need to be on negative all the time. A lot of our inspectors become relatively, given our fees, even though they may go up, are very inexpensive consultants. They've been trained and focused on pharmacy law, pharmacy practice, and best practices to the degree that in many cases they can come in and help improve a pharmacy's operation. So how does the board prioritize enforcement cases? Well, we do this we have an established case priority system, 1, 2, 3, 4. Priorities 1 and 2 are the high risk, most important, do it now types of cases. Priorities 3 and 4 are of lesser importance, but they're not unmeaningful. If you are a consumer with a medication error, you may not have taken it, you may have not been harmed, but that complaint is going to be very important to you. And you would want the regulator to take action to review it just as the one where a serious violation has occurred. So we use the ranking system, and we also have our inspectors in teams. And the team structure itself kind of lends itself to a prioritization in that those inspectors on the drug diversion and fraud team are looking at serious issues involving the movement of drugs from pharmacies to the streets illegally, where, as I learned earlier this week, a bottle of prometh with codeine, $12 in a pharmacy, $1,200 on the street. So that there is a lot of momentum to get those drugs in the pharmacy, outside the pharmacy where they can make some money. Priority 3 and 4 complaints, because they're for the compliance teams, are the med errors, are the dirty pharmacies, are the types of violations that you want corrected, but they're not as eminent as a pharmacy operating, for example, without a pharmacist or someone working under the influence. What are the board case and complaint priorities and how inspectors, I just addressed that one. So how does the board maintain consistencies and investigations and enforcement outcomes? Well, first of all, we start off by ensuring that all cases before they're investigated are first of all reviewed by the supervising inspector, who's going to assign it to one of his or her teams. That makes consistent the way that all the investigations are handled, whether or not one person assigns it or another person assigns it. And that's part of the goal of making your outcomes and your priorities consistent. We're also, and then when the investigation reports come in, they're reviewed by the supervising inspector. We have a second set of eyes going on them, either a supervising inspector or perhaps Ms. Sodergren or myself, or we're in the process of hiring 2 chiefs of enforcement to perform that function. And we've needed to do this because of the growth in the board's enforcement program over the last couple of years.
The board has also instilled Ask the Inspector. So we actually have an inspector that's on call that will, licensees can actually phone call or they can email. And we do respond to those. So that was something new that the board has started this last year, which has been very well received. Does the board plan to adopt any more precedential decisions? That was a question that was asked. The board has one precedential case at this time. Should other decisions be adopted where the board believes that broad public policy is involved that supports the board's mandate, the board will consider adopting the decision as an additional precedential decision. The current one involves a drug diversion. It was a pharmacy that was involved in drug diversion. Implementation of recently enacted legislation. What are the delays in promulgating regulations for Senate Bill 493, and what's the status of the state protocols and rules? And this is one, I guess, was an education to me, not having been in doing these before, how long this takes to try to get these regulations through. However, we have, and thanks to Senator Hernandez for the support in this, California is paving the road in the United States, and we're the first state to promulgate regulations that provide pharmacists with expanded care options. particularly in relation to the advanced pharmacist practice role. As a result, the board established a Senate Bill 493 committee that has met 7 times since June 2014. The board has increased, and actually when I looked at the numbers, we've doubled our number of full board meeting dates in 2015 as compared to 2013. Currently, there are several components of Senate Bill 493. Nicotine replacement therapy, the regulation has already taken effect January 25th, 2016. The hormonal contraception regulation is undergoing a 15-day additional comment period to add documents to the rulemaking file, and this was necessary based on the advice of the Office of Administrative Law. The advanced practice pharmacists, there's 2 regulations. Both have been adopted by the board. Both rulemakings are going to be compiled and will be ready to go by April 1st. By April 1st, and we will send that to the department. Immunizations was adopted by the board, and it's currently undergoing review by the DCA, by the department. And travel medications, the comment period is closed, and the comments received will be considered by the board. As the board was developing these regulations, the board was also required to finalize the sterile compounding regulations, which we have done, and also promulgate emergency regulations to develop a state protocol for naloxone. And that emergency protocol first took effect April 10th, 2015, with the permanent regulation January 2016. Jenny, how does the board prioritize rulemaking efforts?
Well, most of our regulations are in fact major regs. We have one of our licensing programs requires every time we change an item on the form, we have to do a rulemaking for it. Pretty slow and cumbersome. That's not our biggest priority. Most of the other regulations are assessed and taken up in the order with their impact for providing public safety. So the greater the public safety, the more likely we are going to do that first. And the way to point to that is in the last 3 years, as we have moved away from the lessons we've learned in Massachusetts with the sterile compounding, we have taken to overhaul our regulations. And we started it once. We went through numerous iterations working with the profession, and we needed to start over because the rulemaking itself had gotten so complicated you couldn't tell what the language looked like because we added and deleted things so many times. So we started over. That particular rulemaking took us, I think we're coming close to about a year since we started that process, but that rulemaking has taken precedence over everything because we strongly believe that we want those regulations into effect both for the pharmacies in California, particularly the hospitals that need this guidance, and also for those outside the state that are shipping in medication. So it's also a resource issue for the same reasons pretty much everything else is. You can't do everything first, you have to prioritize. And so those with the greatest public safety risk are what we put first. And I've been asked to talk a little bit about, does the board ever initiate rulemaking to take action when anticipated legislation may be taken? How do pending board rules intersect with pending statutory changes, such as those related to drug take-back or compounding pharmacies? Well, generally, legislation is enacted first, and you do regulations to flesh out the requirements in the legislation. So, and sometimes controversial topics that you wouldn't have time to amply address in the legislative arena gets kicked back to the regulator or to another board to address. So that's part of the way that we believe that that's done. With respect to drug take-back, as Dr. Gutierrez said, we just released for public comment. We're halfway through the board's 45-day comment period with the comments to go back to the board at the end of April for the meeting. Drug take-back is something that we've been waiting for the DEA to act on for a number of years. In 2007, our board was involved with the Integrated Waste Management Board in developing pilot programs or sample programs for drug take-back in advance of waiting for the DEA to do something. Because of controlled substances and the way the Federal Controlled Substances Act is written, that if you are not the person to whom the prescribed controlled substance and you possess it, you're violating federal law. And so the DEA was put in charge of basically revising that in a manner where people could give their drugs to someone else to get rid of them, to dispose of them, so that they're not flushed down the drains or thrown into our landfills. So in that particular way, in 2014, in September, the DEA finally did its DEA requirements for drug take-back. The regulations are relatively complex. They run through 50 pages in the Federal Register. We have developed the synthesis of those, specifically what pharmacies have to do if they wish to take back drugs that are compliant with the DEA's policies. There are basically two forms: collection receptacles and mail back envelopes or packages. And so what we've done in our proposed regs at the current time is to take what those federal standards are and put them into a proposed regulation. Few pharmacists would read the Federal Register to identify what their requirements are in terms of meeting the requirements of the DEA's requirements. And additionally, because pharmacies are DEA registrants, if they fail to follow the requirements of the DEA, they run in possible danger of the DEA deciding to revoke their DEA permit, which would basically put most pharmacies out of business because they could no longer handle controlled substances. It's a very serious thing. We want them compliant. We want them able to do this where they want to do it, and we want them to do it safely. In the case of sterile compounding, the board began licensing sterile injectable compounders in 2003 in California after we had 3 deaths in Walnut Creek. And when NECC happened, we immediately did what other regulators were. We were one of the few states at that point that had a licensing program. But we talked to the FDA. We jointly inspected some of the pharmacies that were out there that we knew were doing sterile compounding and that the FDA thought were potentially high risk. And then we also, again, immediately started working to how can we make certain our requirements are appropriate. Earlier in 2013, I'm talking too fast and too much. In June of 2013, we also had another problem in California where this time sterile injectable medication was shipped into California from outside where it did reach patients. And we had some patients in Los Angeles that were blinded by the bad medication that was injected in their eyes. So we had already decided that there was a problem brewing, but we never saw NECC coming, which just changed. As a regulator, if you were regulating pharmacies, particularly those that were doing sterile compounding prior to September of 2013 and didn't do something after 2013, you probably were abrogating your role as a regulator. You needed to recognize that this was a major event, and regulators had to step back and take action. So we did, and we're still working on it.
And I don't want to interrupt you, but I know I'm going to have to leave in a few minutes, and I think Senator Wieckowski will as well, and as soon as Chair SALAS comes back. But I did want to ask a couple of questions before you continue, and I know there are a couple of things that you may want to add to to address some other issues that we didn't ask about. But one is on the drug take-back. I know the program that you've developed and the regulation specifics about a pharmacy may collect medical waste and take it back to the pharmacy. What if the legislature were to develop a mandatory take-back program, which has been discussed here for the last few years? Would you be able to do that, and can the board determine that a pharmacy then would be permitted under those circumstances if we do mandate it?
Yeah, I think the regulations that we're working on is if a pharmacy were to do it, this is how you would go about doing it. What type of liners would you use? What is your what type of DA registration changes need to make? So it's more like the how-to on that side.
But would that fit right into a mandate if we were to?
I don't believe if you mandated something as a regulator, we have regulations to do that. You have the legislature's authority. I don't see that we could override you even if we wanted to.
But would it fit? I mean, you could use
I would.
Within what you're doing as a may could be a
The only thing I'd caution in that, because we have had quite a lot of testimony from pharmacies, is you do have pharmacies that are located inside grocery stores and such. And there is some public issues with having take-back bins right next to the fruit and the vegetables. And there may be other issues that you may want to look at when you start. There also are some pharmacies that are very small, and they may not have enough space. So that's the only thing.
And I can see that, and Senator Wieckowski had a question, but I just wanted to follow up on that particular aspect, because in most of the larger pharmacies, you're walking through a lot of food and everything else before you get to the pharmacy department in the rear. Senator Wieckowski.
I guess the question is the local jurisdictions. I understand that San Luis Obispo and maybe Tulare have passed ordinances mandating pharmacists. I think Sacramento did it, mandated. So how would that fit into the regulatory scheme if the locals have said, it seems like the public wants this?
My understanding of those mandatory, at least from the testimony we received at the board, is that it could be done either through physical take-back or through envelopes. So they could provide envelopes. And I know in San Luis Obispo or one of the counties,
Santa Cruz.
was actually utilizing, some of the pharmacies were using take-back envelopes, and that was sufficient. So they could be either or.
My staff has indicated that doesn't appear clear on your draft regulations that that's allowed, that it's clear that local jurisdictions, if they mandated it, would come in. And since I was the author of one of the pharmaceutical waste bills long ago in 2011, we're still waiting for those regulations because that's included in the bid.
But again, our regulations tell how the pharmacy is to take back the drugs so that we've got a consistent system so that pharmacies and the patients around them are safe. And as Dr. Gutierrez said, the one thing that concerns us is recycling centers. When you go into a recycling center and they're closed, what do people do with the stuff that they want to recycle? They leave it there. That may be fine for certain kinds of products, but with drugs, you don't want someone walking into a pharmacy that's closed with a bag full of drugs they want to recycle or take back. We call them recycling. And if that bin they can't deposit it there, you don't want them to set that outside the bin. And so that's one of the greatest problems we've got in those kinds of centers, but that's not all of them. But no, we have guidance. If you're going to do a collection bin, this is what it looks like. This is how you have to remove liners. This is how much time you've got to do this. This is how you track it.
This is how you change your DA registration.
Right.
And these are, unlike other take-back programs, these do have a street value. It's not like an old battery or paint that no one's going to use. There are recyclable street value with some of the drugs that are being returned.
Okay, if I could just a couple more quick questions. And the implementation of 493, there have been some questions raised about the hormonal contraceptive regulations and providing access to that the legislation was intended and whether it is maybe creating an obstacle. I don't know if it is, but should clarifications be made to the regulation to reflect the existing protocols specifically related to a patient being able to provide health information like blood pressure or items known from technology, like they get something from their Apple Watch or their smartwatch, so that we can advance that to make the access a little easier and provide greater information?
We believe that the role of the pharmacist with the hormonal contraceptives is to just add increased access. Currently, when we had providers testify, they even, obstetricians and gynecologists, that they do take blood pressure when they are administering or prescribing estrogens. It's not for every contraception, but it's certain drugs that you do want to make sure that you do check the blood pressure, and that is actually in the guidelines that we, from our experts, that were provided. I think the guidelines that Dr. Basink had actually provided us.
Thank you.
Thank you.
Thank you. Thank you, Chair.
Thank you.
Senator Hill.
So just a couple more questions. I know the senators have to head off to floor session, just like I headed off earlier, if anybody was curious, me and Assemblymember Breaux and the others. But I just want to ask a couple questions, and I don't believe they've been asked already, but one is, I know in last year's budget we had, with the Department of Justice, had funded the CURES program, and just wondering how that's working with your industry and kind of where we're at.
Why is it, I made quite a statement in our budget hearing last week. Never mind. Sometimes it's not necessary to go into it. We strongly support the use of CURES. We think that the CURES system needs to be upgraded as quickly as possible. It needs to be provided with the resources so that it's quickly usable, it's accessible, it's reliable, and people actually want to use it. Because it's one thing we can do to help stop some of this proliferation, the overprescribing of opioids. So once it becomes easy, it doesn't disrupt the operations of either the prescriber or the dispenser, you'll get more used to it and you'll drive there. And the new system has some wonderful accoutrements. So we strongly support it. We're right around 60% of our pharmacists are registered in the system. I think some of the last 40% are going to pose some challenges for us. We know that they're going to be a little harder. The ones that are more attuned to it have probably already registered. Those that have not are going to be a little bit harder. We're sending postcards through the mail to our licensees because we want them to be ready. We want them fully compliant by July 1.
And just from a practicing pharmacist perspective, what you can identify with the use of cures is your doctor shoppers. I mean, because sometimes if someone really wants to get these drugs, they'll go to an urgent care, they'll go to their family doctor, and nobody really knows because there's so many doctors and so many pharmacies involved. This gives you a true source of truth of what's going on with that patient. I find it invaluable.
Okay, thank you. And what about, since we're talking about technology, but what about the BREEZE program and how that's still operating and working?
We're not part of BREEZE. We started and then we stepped back out of BREEZE.
Okay. Why did you guys step out of BREEZE?
We have an ownership structure that would have been difficult to track in the BREEZE parameters. We are one of the few boards that ownership of a pharmacy as it tracks through the system is a big deal to us. And it would have made it very cumbersome to be able to track ownership because of the way the record was set up, among other things. But that was principally it. I don't know whether Ms. Sodergren wants to say anything more, but she actually was our point person that literally was going through the program design with BREEZE folks. So,
Thank you. Just one more question. Do other state pharmacy boards do their own inspections for out-of-state compounding facilities?
no, we are unique in that.
We're unique in that. Okay.
We take our protection role very seriously, and we do the issue with the Massachusetts. That was an out-of-state pharmacy. They were shipping drug into California. We were very close to have been impacted had we not been doing this.
Most states don't have the resources we have either, and nor do they have the expertise we've got. We've got over 10% of the nation's pharmacies in this state, and we have a larger workforce of inspectors than other states have, in part because we're inspecting sterile. We've got 4 staff to do in sterile compounders. But it is a lot of work to send inspectors out of state. But we believe that the public needs to rely on and trust the medication that they're being administered, in this case, particularly in hospitals where a lot of these products go.
Okay. Thank you. Anything else you'd like to share? Thank you for your testimony.
Thank you very much for your time.
Okay, let's go ahead and bring up the panel B, professional groups, organizations, and individuals. Just come forward.
Good afternoon, Mr. Chair and members. Brian Warren with the California Pharmacists Association. Nothing like a full day hearing to welcome in the daylight savings time, so.
Absolutely.
Full day.
We saved you for the afternoon.
Yes, thank you. We are pleased to support the staff's recommendation to continue the board's sunset extension. And with regard to the remaining issues that were highlighted in the committee report, we very much look forward to working with the board and the legislature and these committees towards addressing all of those issues in a very productive manner. Thank you.
Thank you.
Good afternoon, and thank you. My name is Marianne Bobro. I'm interim CEO for California Society of Health System Pharmacists. We too support the board's efforts, and our focus, as always, is on patient safety. And as long as there are safeguards in everything that is being proposed moving forward, then we would support those as well.
Thank you.
Good afternoon, Mr. Chair and members. Gregory Kramer with Planned Parenthood Affiliates of California. Echoing some of these comments as well, we also support the recommendations highlighted specifically under issue number 4, dealing with backlogs for licensure, and we'd like to thank committee staff and the Board of Pharmacy for working with us, because we have over 115 clinics in the state of California, and significant backlogs have been plaguing some of our operations in recent years, and we're relieved to hear that that has now become a thing of the past, but we support the staff recommendation as well to have a piece of legislation to codify a 30-day processing time along with other streamlining measures.
Got it. Thank Thank you. I'm just looking at issue 4, just to make sure we're on the backlogs. Okay, thank you. Let me ask if there's questions on the dais. Sure. Assemblymember Bro.
Thanks, Mr. Chairman. I just wanted to ask all of you if you had any opinion on the increased fees that the board proposed.
I think we would defer to, the board's fiscal analysis, looking at its fund condition. We don't have an active position on the increased fee proposal yet, but it's something that we're looking closely at. We do want to ensure that the board is adequately staffed to be able to sufficiently meet all of its statutory obligations. So that's still something that we're evaluating.
Thank you.
And I would agree with what Brian has just said, and knowing what happens in economic conditions and with the hiring of additional inspectors, I believe very strongly that there's probably a great need for that.
And PPAC hasn't officially made a position on that, but we'll put it under further review and follow up.
Okay. So thank you. Doesn't sound like there's outrage. So thank you for that testimony. Anything else you'd like to share before we move on? No. Thank you guys for being here. I know it's been a long day. We're